You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for March 10th, 2023. This week, the ACC Recap number 1, we'll talk about sports, bempedoic acid, statin intolerance, NASCARs, tricuspid valve interventions, and another strike against revascularization in stable coronary artery disease. Before I start, let me make a couple comments on the ACC meeting. I think the first thing to say was that it was nice to be normal again and be in person. The second thing is that I was surprised about the crowd. During the poster sessions, which were held alongside posters taped onto boards, as it should be, attendance was pretty decent. The opening session was standing room only. Now, the press room was sparsely attended, but media, I think, have learned that they can cover the meeting remotely. And sure, of course, you could say it was New Orleans, which is a great place to have meetings, but maybe I was a bit premature in worrying about the demise of big meetings. We'll see at ESC and AHA coming up later this year. Final thing is, I want to say I'm very grateful for all those who came up to me to offer thanks about the podcast. Seriously, every Friday, I talk into this microphone and I hope folks are listening, so thank you times 1,000. All right, first topic today are 3 studies in sports cardiology from ACC. I want to start with this because I like sports. Now, one of my biases has always been about overly strict restrictions on returning to play. I really don't like keeping people out of sport. Well, 2 late-breaking studies at ACC suggest that patients with significant genetic heart disease can return to participate in play, that is, with proper evaluation and follow-up. Professor Rachel Lampert, an electrophysiologist at Yale, presented results of the LIVE-HCM study. This was an observational study of 1,600 patients with hypertrophic cardiomyopathy who aimed to participate in vigorous sport. Now, of note, 8% of these patients were gene positive but had no obvious disease. The modifier vigorous and HCM usually don't go together. I mean, for as long as I can recall, doctors have been fearful of letting patients with these thick, stiff ventricles exercise vigorously. At baseline, hypertrophic cardiomyopathy associates with a higher risk of ventricular tachycardia. We've long felt that this risk is even higher with exercise or vigorous exercise. Lampert and her colleagues broke up the 1,600 patients into 3 groups: vigorous exercisers, moderate exercisers, and sedentary. They then looked at event rates in 2 groups, the vigorous versus non-vigorous individuals. And of course, the non-vigorous could include both moderate exercisers and non-exercisers. The primary endpoint that they chose was death, resuscitated cardiac arrest, syncope due to an arrhythmia, or an appropriate shock from an ICD. These occurred at very low rates, and they were not substantially different in the 2 groups. This led Lampert to conclude at the meeting that these data, quote, do not support universal restriction of vigorous exercise in patients with HCM. In the same late-breaking session, undergraduate student Catherine Martinez presented another study, an observational analysis of 76 elite athletes with genetic heart disease who gained a return-to-play approval from 4 expert centers in the U.S. The included athletes' most common condition was HCM, hypertrophic cardiomyopathy, followed by long QT syndrome. The centers had a 3-step protocol, and this is important. First, they had an initial evaluation. Second, they then had a frank discussion on the risks and harms of playing. And the third thing was that they informed the coaching staff of the athlete about the condition, and then athletes had to purchase a personal AED. They had to avoid QT prolonging drugs, and they had to keep their follow-up. Now, similar to the LIVE-HCM study, with this three-step process, event rates were tiny. Only 3 athletes had non-fatal events, and none of which were directly related to the intense exertion in elite sports. The take-home message from these authors was similar to Professor Lampert. That is, when there was careful evaluation by experts, and there was shared decision-making, and a specific plan to return to sport, these can be put into place for the highest-level athletes with genetic heart disease. The third sports cardiology study was a featured research session, and this was called the Masters at Heart study. This is a good one. This is a Belgian study of about 600 middle-aged adults who were recruited from an online survey about the effects of lifelong exercise on, get this, sit down, coronary atherosclerosis. That's right, these investigators were interested in studying the coronaries of long-term endurance athletes. And boy, did they ever study these individuals. And core to this study is the paradox of endurance athletics. We know that exercise lowers the relative risk of cardiac events, yet numerous imaging studies have found high rates of coronary calcium in these endurance athletes, especially those who run multiple marathons. The investigators made 3 groups: lifelong exercisers, late onset exercisers, people who started endurance exercise later in life, and normal exercisers. Now, of note, the control group here, the normal exercise, they had minimal heart disease risk factors. They took few, if any, medicines, and they had 122% of normal VO2 max. So these were extremely healthy controls. The European Heart Journal published this study, and the main findings were a couple. First, lifelong exercisers had significantly higher coronary artery calcium, and this confirms previous work. Lifelong exercisers had a higher percentage of multiple coronary plaques, plaques greater than 50%, and plaques in the proximal coronary vessels. They found no significant differences in the mixture of plaque types in the 3 groups. About 2/3 of the plaques in each group were calcified, and the remainder were deemed non-calcified or mixed. Now, when they subdivided and they looked into only at the non-calcified plaques, they found that lifelong exercisers tended to have a higher prevalence of multiple plaques, plaques greater than 50%, and proximal plaques. Now, they also looked at vulnerable plaques, so-called vulnerable plaques. These were extremely infrequent in all 3 groups of these healthy middle-aged people. The authors concluded that lifelong endurance sport, relative to a generically healthy lifestyle, was not associated with more favorable coronary plaque composition. And this is pretty surprising, isn't it? I have 2 quick thoughts. When I was in Indianapolis training at IU, Indy was a hotbed of amateur sports. The Cath Lab conferences frequently featured cases of runners, cyclists with these terrible proximal coronary disease. Now, decades later, I've had fellow bike racers have myocardial infarction. Now, the question in the cycling group when someone has a myocardial infarction who's seemingly healthy and strong on the bike is, how did that happen? Well, this kind of data is at least somewhat supportive. Now, the main limitation, of course, is that images of coronary arteries are surrogate markers. It's possible that more calcification is actually protective and that it creates more stable plaques. And we definitely need more data on outcomes. And finally, I want to say something about what the authors proposed, this J-curve, wherein being sedentary or too little exercise increases risk. We all get that. But at the other extreme, perhaps they hypothesize that too much exercise also can increase risk. And this is an attractive thesis, but it's extremely speculative. I can cite at least one study that shows former Tour de France riders have great outcomes. And of course, the final problem with this theory is that even if it was true, I don't think many lifelong endurance athletes like myself would modify our behavior, because for most of us, we do this because we can't not do it. Almost no one I've interacted with or raced with felt that it was a healthy endeavor. Okay, next topic is the CLEAR outcome study. And I realize that I have spoken about bempedoic acid for the last couple of episodes, but hear me out on this. We learned the results of the bempedoic acid CLEAR outcomes trial at ACC, and there is more to talk about than just the trial results. All right, quick summary. 14,000 patients with heart disease or high risk for heart disease and statin intolerance and a high LDL cholesterol. The mean LDL cholesterol level in this trial was 139 milligrams per deciliter, so they're starting at a very high level. Bempedoic acid reduced the LDL cholesterol by about 20%. The MACE composite primary outcome of CV death, MI, stroke, revascularization was reduced by 13%. So a hazard ratio of 0.87, confidence intervals that went to 0.79 to 0.96, a p-value of 0.004. So this was definitely signal, not noise. But the absolute risk reduction was only 1.6% over 4 years, and there were no differences in CV death or all-cause death. The drug reduced only non-fatal outcomes. Now, notable was that in the figure, in the New England Journal, there were 4 Kaplan-Meier curves displayed. They displayed the primary endpoint, the 3-component MACE endpoint, MI, and coronary revascularization. Now, why would I even note what was in figure 2 of the New England Journal? Because these were the components that were reduced. The CV death and stroke, both components of the primary endpoint that were not reduced, were not included in the main figure, nor was all-cause death. That was not changed. Another factor pointing to a very modest effect was that the baseline LDL was high at 139. The risk reduction going from a high LDL level is going to be greater at higher levels. I think this is similar to why there's more bang for the buck for treating very high blood pressure than, say, milder hypertension. We can compare the risk reduction in CLEAR outcomes to another non-statin drug, ezetimibe. This ezetimibe significantly lowered a MACE endpoint in the IMPROVE-IT trial, but the reduction was measly at 6%. But perhaps this was because the starting LDL cholesterol in IMPROVE-IT was at 94, significantly lower than the 139 in CLEAR outcomes. Now, these statements speak to the modest effect size of bempedoic acid. One positive I have to say is that the Kaplan-Meier curves in CLEAR outcomes did seem to separate gradually over time. This is consistent with the notion that the longer exposure to low LDL cholesterol, the greater the benefit. Safety was mostly okay. Bempedoic acid has no effects in the muscles, so myalgia-like complaints did not differ. That's good. But there were more cases of gout and cholelithiasis in the bempedoic acid group. Now, what should happen? Bempedoic acid is already approved for use in other familial hyperlipidemia. Here is one worry that I have. It's about not using statins. Statin drugs have a much more robust evidence base, a larger effect size in reducing MACE outcomes. They should be the preferred agents. But then there is the matter of statin intolerance. Now, my friend Bogdan Inaki is an electrophysiologist in Monaco. He's got an excellent Twitter feed. And he captured the sentiment many of us worry about in one tweet, and I'll link to it. He said, after years in which we minimized almost every account of statin intolerance, starting today, statin intolerance is a very serious matter that afflicts our patients and is a large public health issue. Now, I know he's being funny, but I think he captures it. In blinded randomized controlled trials and in the elegant Samson trial, there is convincing, I mean super convincing evidence that statin intolerance almost doesn't exist. In Samson, for instance, more than 90% of the symptoms of statin intolerance occurred during the months patients took placebo tablets. But now, Bogdan and I, and perhaps you too, are afraid that statin intolerance will become a marketing campaign, kind of like the Forgotten Valve campaign of tricuspid regurgitation. This would be bad for patients because statins are better and far less expensive. Now I want to tell you about some observations I made at ACC. Just the observations, you make the conclusions. The PI of CLEAR Outcomes made 2 references during the presentation to a packed house in the main ballroom of the possibility of using the combination pill of bempedoic acid and ezetimibe. This, he said, would accomplish a 40% reduction of LDL cholesterol, which is big. But I didn't think much more about the comments. But then he said it again in the press conference. Now, later that day, I was walking through the expo. I was cutting a corner, looking at my phone, and almost walked into a car. Not just any car, but a NASCAR adorned with the label of a drug called Nexlivit, which is a combination drug of, you guessed it, Bempedoic and ezetimibe. The company that makes it, I looked up, is Esperion, the same company that makes bempedoic acid and sponsored the Clear Outcomes trial. That's it. I'm not saying anything else. I'm just making these observations. Finally, in conclusion, for me, in clinics, we ought to discuss the evidence or lack of evidence for statin intolerance with our patients. We should resist the urge to easily succumb to more expensive drugs with far less evidence for benefit. Okay, benefit. What a great segue to another trial with interesting interpretations. TRILUMINATE. ACC also brought the results of the TRILUMINATE trial of transcatheter edge-to-edge repair versus medical therapy in patients with symptomatic isolated tricuspid regurgitation who were poor candidates for surgery. Gina Colada of the New York Times covered the results, and here was her lead in the New York Times, quote, "For the first time, patients with damaged tricuspid valves in their hearts might have a safe treatment that actually helps." Now, I don't think so. And this one really frustrates me, and I will try to keep it professional, not get cynical, but this one really tempts you to be cynical. TRILUMINATE randomized 350 patients, aged 78 years, 55% female. The investigators chose a hierarchical composite primary endpoint of death, need for tricuspid surgery, hospitalization for heart failure, or quality of life as measured by the KCCQ questionnaire. The trial duration was 12 months. Now, they measured multiple other secondary endpoints, and one that I will come back to is the 6-minute walk test. The bottom line is the results of TRILUMINATE were positive, but Gina Colada was likely wrong about it being a helpful treatment. And you have to go back and look at the components of the primary endpoint. There was no difference in death, no difference in the need for tricuspid valve surgery, and no difference in heart failure hospitalizations. Of these first three hierarchical endpoints, they're all negative. The only difference in this trial was a better KCCQ change in the surgery group, and KCCQ scores reflect how a patient judges their own well-being. They're subjective. The authors analyzed the data with a win ratio, and it's a different and new statistical technique that estimates the likelihood that one or the other treatment is better, but it does count more serious events that are given higher priority. Now, the win ratio was positive in favor of tricuspid valve clipping, but only because of the KCCQ. And as I have said, none of the other endpoints were positive. Even the 6-minute walk test did not differ. So the fatal flaw is that there was no placebo. Patients in the surgical arm knew they had an invasive procedure. Patients in the medical arm knew that they did not have an invasive procedure. Now, as a limitation, the authors cited the Hawthorne effect as a possible explanation. But I don't agree with this. The Hawthorne effect occurs when people change their behavior because they know they are being observed. The KCCQ questionnaire asks people how they feel about their own well-being. And I've discussed the necessity of placebo effect on this podcast many times. I mean, we have the reversal of transmyocardial revascularization, TMR, internal mammary artery ligation, pacing for hypertrophic cardiomyopathy, and even PCI of single vessel disease and orbita. Now, there was some discussion on Twitter about the difficulty or even impossibility of doing a sham control. But the PI of the Orbita trial, Dr. Rasha Alami, shut all this down with a tweet. Here's her tweet, quote, "Of course we can do a placebo-controlled trial of a percutaneous procedure like this," she wrote. "We owe it to our patients to stop producing unblinded data that, in my humble opinion, does not inform clinical practice." And what really bothers me about this story is that the authors surely know the importance of placebo effects when including a quality of life primary endpoint, but they still chose this design. The buzz from the conference, and obviously in the New York Times, was that TRILUMINATE was a positive trial. Transcatheter edge-to-edge repair offered patients with TR hope. But that's not what I see, not at all. The KCCQ difference could easily have been placebo effects. And the stakes here are super high because of the epidemiology of TR, right? It's super common in older patients, often load-dependent, it's hard to grade. TR is everywhere. Well, TRILUMINATE is a pre-market approval study, and FDA will have to decide on its approval. If they accept these results and approve the device and CMS creates a code for it, I'm afraid there will be a deluge of low-value care. Sadly, and I don't say this lightly, I really think regulators should say no. Now, the proponents might counter, but Mandrola, patients with TR feel terrible. We need to offer them something. To that, I would say what I always say. The burden of proof is on the proponents to show me which patients benefit in a proper trial. Show me lower CV death. Show me less heart failure hospitalizations, or a better 6-minute walk test against a placebo control. Okay, final topic today is a sub-study of REVIVED-BCIS. Professor Pereira from the REVIVED-BCIS trial presented a sub-study of that important trial looking at the effect of myocardial viability, functional recovery, and PCI on clinical outcomes in the main trial. Recall that REVIVED-BCIS is one of my picks for one of the most important trials of this decade, really. Of all the trials that show the lack of benefit of PCI over optimal medical therapy in chronic CAD, REVIVED-BCIS was the most definitive. The main results were clear and totally upended the common practice of taking patients with new left ventricular dysfunction to the cath lab for assessment of coronary angiography. This is super common. Here was the main trial, just a review. REVIVED-BCIS, 700 patients randomized, all had to have 4 things. Get this, a bad LV, multivessel CAD, the lesions had to be amenable to PCI, and there had to be a large amounts of myocardial viability. One group got PCI plus medical therapy, the other group got medical therapy alone. And yes, they left patients with severe CAD and bad ventricles on medicines, and there was no difference in any outcome at 3.5 years. Not even ejection fraction improved. It was a shocker. Revascularizing large areas of viable myocardium did not improve LV function on average. I'll link to the paper. It's in the New England Journal of Medicine. This, I think, rocked the world of proponents of PCI. How could this be? Now, one question that came up, there must be, they said, within that trial, a subset of patients with just the right amount of viability that would benefit from PCI. And that was the focus of this pre-specified analysis of the main trial. First, I will tell you how they did this, but then please listen to the conclusions, which I think are really disruptive to the status quo. Viability was assessed in 3 ways. 1, the volume of hibernating myocardium. Another, the total volume of viable myocardium. And the third way, scar burden. They then correlated each of these 3 components of viability with outcomes. Hibernating LV volume. There was no predictive effect on all-cause mortality or heart failure hospitalizations. Total viable myocardium. This was marginally significant for predicting the primary endpoint. But scar burden. The adjusted composite endpoint hazard ratio per 10% increment in scar burden was significantly increased at 1.18. In other words, more scar meant worse outcomes. Scar burden seemed to be the best predictor of outcomes. But now for the really big finding. Was there a treatment effect based on these viability parameters? The answer, no. The extent of myocardial viability, regardless of the viability definition, did not highlight any group with a reduced risk for death or heart failure hospitalization, or a group with better LV functional recovery from OMT plus PCI compared with OMT medical therapy alone. There was also no treatment effect on LV recovery. In other words, there was no viability parameter affected by PCI plus OMT. It's crazy, isn't it? No group did better with PCI in this substudy. Not those with tons of myocardial viability, not those with low scar burden. The conclusion of the authors, PCI did not improve prognosis or LV recovery in ischemic cardiomyopathy compared to medical therapy, regardless of viability characteristics at baseline. My conclusion, the main trial results hold up. this study fails to find a heterogeneous treatment effect wherein you can select out ischemic patients who will improve with PCI. What is more, this finding is similar to the Stitch sub-analysis. This is Panza et al., New England Journal of Medicine, 2019, in which they also found the presence of viable myocardium was not associated with long-term survival in a trial of CABG versus medical therapy in patients with ischemic cardiomyopathy. So, not only does this disrupt the practice of bringing patients with bad ventricles to the cath lab for angiography assessment, it also calls into question the whole notion of myocardial viability testing. I mean, gosh, we have spent a lot of time and effort, money, with viability for predictive purposes, and this study really calls into question its utility. All right, that's it for this week in cardiology. This is ACC Recap number 1. Next week, I'll do another recap of ACC. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please consider giving us a rating, writing us a brief review, and if you have disagreements with me, please let me know. I'm always open to criticisms because I learn from it. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.